Okay, guys, so this is going to be your PowerPoint for the week that we were not on, which was last Friday. So this is going to be for week 4. We're going to go ahead and start out with the 2 NCLEX questions because, again, as I always have said, anything that we've reviewed in the past, such as quizzes or NCLEX questions, could potentially be something that might show up on one of your quizzes or tests in the future. And you do have your quiz on Friday. So not sure which video you're watching first, but I did have another video that is posted that is an overview of what's going to be on your quiz for this Friday to Saturday. So let's go ahead and start with these 2 because who knows, one of these might be on there. And also, of course, I want you to understand why it is correct or not correct, as well as even though it may not completely go exactly with what we're talking about, because both of these actually have to do more with they're more addiction questions rather than anxiety and depression. But again, the more we learn, the better. And these are more about learning the strategies. So, okay, let's just do these. I was just going to say together. Obviously, you're not on, but I will explain the strategies for these 2 questions first. Then we'll review the PowerPoints. And then also anything from the reading that I thought might be important. But again, please, please, please watch that 12-minute video on what to expect for your quiz on Friday. Okay, so the first question asks, so the nurse cares for, my apologies, my phone. The nurse cares for and I always miss this and I keep forgetting to add it back in, for a client 2 hours after a percutaneous liver biopsy. Which finding requires an immediate intervention by the nurse? Okay, so as we've talked about before, we're going to look at certain things here. So usually time frame can be important. So I'm noticing that this client had this liver biopsy done 2 hours ago. So that's fairly recent, right? And this is a procedure. So for those of you who are not familiar with the term, percutaneous is, excuse me, percutaneous is basically going through the skin. And when we do a liver biopsy, that's how we actually do the liver biopsy. So there's several ways, as I'm sure you know, to do biopsies by either using a scalpel and cutting out tissue, or you can actually remove tissue with a large lumen syringe. So basically what they'll do is they'll use, of course, an ultrasound to make sure that they're going to go into the liver and make sure not to puncture any other part of this patient's peritoneal area or whatnot. So side note, if you don't know this, and I always like to give the side notes, the liver is an organ that is very vascular. So when somebody is struggling with any type of issue with the liver, and it doesn't always have to be addiction. I mean, the liver can have issues on its own. But with the liver just in general, biopsy is usually going to be one of the last things that we do because it is so vascular. So usually we'll start with labs and look at things like functions that the liver does. We know it creates albumin. We know it helps create our blood clotting factors. We know it does this. We know it does that. So we usually will start with that, get a baseline, see what's going on. Are we within range? Then from there, we're going to usually go to ultrasound, potentially a PET scan or some sort of MRI to see. Physical, of course, and history are very important. You can actually feel the liver through palpation. It's a pretty deep palpation. It's a little uncomfortable, and that would be on your right upper quadrant where your liver is located. And then the biopsies usually last, again, because it's pretty vascular. So we want to, just as a side note, just for fun learning. Okay, so we have this vascular organ that we are taking a biopsy, or that we have a biopsy, that we just have this patient 2 hours after it's done. Okay, so this is pretty recent. And now, keyword there, which finding requires an immediate intervention by the nurse? So this means it's something important. So immediate. Let's see our options here. So number 1, the client is positioned slightly on the right side with a pillow under the head. And I'm going to do this a little different. Sometimes I read them all. I'm going to go one by one and explain it just to kind of get this done, not faster, but I want to get to the other stuff. But I also, I mean, you can always fast forward. But I want you to have the right answers, because this is going to help you with your NCLEX in the long run. Okay, so number one is actually a good thing. So some people might think, oh wait, well, if this organ is on the right side, we don't want to put them on the right side because of pain, tenderness, and that's not a therapeutic measure, right? But if we look, remember those just tiny little words there. It says the client is positioned slightly on the right side with a pillow under the head. So actually the reason why we do this is to help with slight pressure, to actually what I just said about being vascular, to help kind of compress that area. Because they put that word, that changes the whole potential answer right there. So I like this answer as far as it not being correct. So this is something that I would not go, oh my God, we need to get them off the right side, and it wouldn't jump out at me. So, but of course we're going to continue reading, because who knows, maybe there's nothing else to pick from. So we're crossing our fingers that we find a good answer. So number two, the client reports aching, throbbing pain that goes to my right shoulder area. Well, I don't like that my patient is having any sort of aching or any sort of pain or anything in regards to pain. However, it's not where we did the surgery, but I do know, remember, don't make up stories, because we can make up a whole story that has nothing to do with the question. So at this point, I'm just going to look at it and say, this might be something that I might pick. So I'm not going to eliminate it. But now I'm going to compare, and I like to do this different ways every time, so you can pick the way you like to answer questions. I, at this point, would go, okay, what's more immediate, number one or number two? At this point, I'd say number two, just because the first one is slightly on the right side. I'm not concerned. This one, they're having pain in their shoulder. I would think that's more immediate than number one. Number three, the client states, I do not want to take the stool softener ordered for tonight. I mean, if there's a medication ordered, of course that's, I care that they don't want to take it. And even though it doesn't say it here, and again, I'm not making stories up, but they probably aren't on some sort of medication. And this is where students tend to go, or the thinking, oh, opiates, constipation. So, I mean, it's concerning to me enough that I would like my patient to be comfortable and not get constipated, or, maybe do some education. But is this something immediate in comparison to something else? And at this point, I would say probably this is not going to be the right answer. And then we come to number four. And then this is where the beauty kind of unfolds. And really, if you take nothing else out of this, this is where you can really help differentiate sometimes between answers, and it could actually get you the right answer, even if you don't really know much about the procedure. So let's take a look at number four. The client states, my stomach feels tight and reports increased abdominal pain. So there's a couple things in that sentence. Number one, we know, so now I'm really looking at between 2 and 4 at this point. Where's the liver located? We know already, at the right upper quadrant of the abdominal area. So where was the surgery performed? And it says right here, my stomach feels tight. So in the stomach area. So we obviously know that the stomach and the peritoneal cavity are not the same thing, but my stomach feels tight. Well, what could be happening? Compression, right? Something's compressing the abdominal cavity. And then increased. That's a very important word. Why is this patient having increased abdominal pain? And this is where the procedure was done, was in the abdominal area. This is going to concern me very much over number 2, because of a couple reasons. Number 2, first of all, NCLEX is trying to trick you. So this is a question that I teach for Kaplan, and I have the rationale for it. So you're doing one of 2 things. So if you haven't learned this yet, fun fact, the gallbladder has referred pain to the shoulder area. So that's one thing that they may be trying to throw at you. People might think, oh, no, it's the liver. No, it's actually the gallbladder. And in this moment, I'm blinking. Is it the right or left? It doesn't matter because it doesn't even say on here which shoulder it is. And the other reason also is because this procedure, they may be using the laparoscopic procedure, right? And when they do that, they're going to pump up the stomach with CO2, and that can move around in the area and actually cause shoulder pain. because it kind of has nowhere else to disperse. So that can make people think that number 2 is correct. But let's pretend that is the case, and that the patient is actually having aching, throbbing pain in their shoulder due to the laparoscopic procedure. Which one is still more immediate? The shoulder pain because of the laparoscopic procedure, or number 4, the stomach feels tight, so they're probably having bleeding going on because there's nowhere for the blood to go. So it's starting to fill up in the peritoneal cavity and having increased abdominal pain. It's going to be where the surgery was and potential bleeding, because even if you didn't know the liver was vascular, you can think, wow, they just had a biopsy, this could be happening. So that's kind of the very long rationale for why number 4 is right. And I could even go further. I'm not going to, but if you do have questions about it, please let me know. It's harder to explain this without you guys actually in front of me, because then of course you could ask questions and be more engaged, but hopefully that was helpful. Okay, so the second one, I know it's LVN, but I do actually use both LVN and RN questions, just as a side note. And my LVN, I always like to say this. So I started as an LVN, as I have mentioned before. That test was actually harder, and I hear this from a lot of people as well. They found that the VN test was more difficult than the RN one. Not sure why, but they did. So I like to throw in some questions from both. So if you ever see a book that's a VN question and wonder why I'm putting it in there, they're all valid. It's about the strategy, right? Okay, so let's go through this one and then head into our depression and anxiety conversation. So, or I guess me conversating with myself. So the LVN is reinforcing teaching for a client who is scheduled for a paracentesis. Which of the following statements by the client indicates that teaching has been successful? So we need to know what a paracentesis is, and we're reinforcing teaching. So there's a couple things that we want to look here. Number 1, it says, which of the following statements by the client indicates that teaching has been successful? So are we looking for something right or for something wrong? Because you're going to get both. So here we're looking for something correct. We're looking for our patient to basically, afterwards we gave them teaching, to be able to teach back, and we're looking for them to say something right. But sometimes it'll say, and we've done questions like this, it'll be the opposite. Which one shows that teaching was not successful? So we really want to make sure that we don't get confused, and that's why we take our time, we read it, and that's why I like to say, number 1, I will be in surgery for less than an hour. Does this show that my teaching was successful? Because it keeps my mind remembering what I'm doing, especially during your NCLEX when your anxiety might be a little bit or a lot bit elevated. Okay, so I'm looking for something correct. A paracentesis, if you're not familiar with it, is, again, it's a large lumen needle where we are basically entering the abdominal cavity. If you didn't notice, I picked these 2 questions on purpose because they're similar. And usually, not always, but usually this procedure is done palliatively for those who are having issues with their liver, severe fibrotic liver or cirrhosis or end-stage liver disease, where the liver is unable to, I don't want to go too deep into it, but it is interesting, and we'll go further into it during our addiction week, which will be my favorite week. I can't wait, other than pharmacology, of course. And we have to think about, like I mentioned earlier, what does the liver do? So one of the things that the liver does is it creates a very, very large protein called albumin. We've talked about this before, I believe, third spacing and things like that. So this is a question, it's a different question, but similar to that. So basically what happens is the albumin, I say it in very simple terms because I like to keep things simple, especially because if I'm explaining it to a patient, I want to keep things as simple as possible, unless they want me to take it into a higher level thinking, or maybe they understand it more or whatever. I meet them where they are. So when the liver's not creating the albumin, as we've already talked about, unfortunately, and if your liver's not working properly, we get this unfortunate, usually hypertension in general, because there's so much pressure happening in the portal or the different vessels in the liver, and you'll get that hypertension. actually in the liver in itself. There's so much pressure building. It's not happy. It's not working well. It's angry. If you've never seen a picture, please look up cirrhotic liver. It's just absolutely, and I've worked with obviously these patients. I do work with these patients, and it's just heartbreaking. So we go in there basically, and I'll give you an example. I think I gave this last time, and it was the worst case I'd ever seen. Maybe a female who probably normally weighed 90 to 110 pounds, very petite, and she looked 8 months pregnant, but she wasn't pregnant. It was all fluid because she was in fibrosis. She wasn't even cirrhotic. So she was not in liver failure, but again, everyone can react differently. So we'll go in there, same thing with an ultrasound guided, because we want to make sure that we get into the cavity without puncturing any of our organs. And then we take out fluid. And it's palliative, because if your liver's not working correctly and you don't either stop what you're doing, and hopefully your liver can repair itself, or you get a liver transplant, this is going to keep happening. Okay, sorry, that was a very long description, but for those of you who are interested, can listen to it. If not, you can just, again, keep fast forwarding to the answer part. Okay, so number one, we already went through that. So I will be in surgery for less than an hour just to show that teaching has been successful. Well, I can already tell you right now, I know this isn't right, because a paracentesis isn't surgery, it's a procedure, right? And I know if we were on visual and talking, somebody would probably say, what is the difference between a procedure and surgery? I mean, really, it has to do with this person, number one, is awake. They're not unconscious. So they're awake while you're doing the paracentesis. They may be on some medication to help them relax and, of course, numb the area. And we're not puncturing into a large area of their skin with a scalpel, right? So this is a procedure, not a surgery. So I already know that one's not right. Number two, I must not void prior to the procedure. Would this show that my teaching was successful for a patient who's having a paracentesis? So voiding, as we know, is urinating. It says I must not void prior to the procedure. So in certain procedures, we don't want our patients to void because we want the bladder to be pushing up on an organ potentially. For this procedure, we don't want that. There's already enough pressure in the abdominal cavity, so we do want them to void. So that would not be the correct answer. And again, even if you don't know that, really making that connection between, okay, they already have all this fluid in here. If the bladder was also full, that's only creating more pressure. That's not going to be helpful in the procedure in general. But let's pretend we didn't know that, and let's hold on to number two because you don't know. Let's just say that. So that we can compare. So we know number one's not right. We're not sure about number two. Number three, the physician will remove 2 to 3 liters of fluid. Would this show that the patient understands what I'm saying, basically? And this is actually the right answer. A lot of people don't pick this one because it is that's a lot of fluid. That is a lot of fluid. The most that that I've ever seen be taken out, and what the research shows, is 4 liters. And even that, I mean, that's a lot, right? Think about orthostatic hypotension. This is a big procedure as far as what you're taking out of the person's body. And that's a lot of fluid at once. This doesn't take very long. Again, depending on the person, but the fluid's coming out of the body pretty fast. So that's a lot of fluid. And so that is correct. So 2 to 3 liters of fluid is usually why we would do a paracentesis. Because why are we doing this? Palliative care, think of breathing, all that pressure on the lungs, right? If anyone's ever been pregnant, I have not, but I mean, just think about it. You have this large area on your abdominal cavity. When you lay down, imagine how hard that must be to breathe. That's why a lot of people who are pregnant, once they start hitting, 7, 8, 9 months, they start to sleep with some pillows, more and more pillows, because it's hard to breathe because you have that pressure. Okay, but let's still finish. So I'm going to keep number 2 and number 3, and then number 4, I will lie on my back and breathe slowly. So for this procedure, it's not that it's wrong. You are usually on your back, but you're not flat on your back. And this is actually why I specifically picked this question, is because most people will go between number 3 and number 4. So at this point, I now that I know what a paracentesis is, well, let's say I'm a student and I'm like, well, I know what this is. I know the procedure. Which of these is going to be the most successful for patient teaching? I'm going to, even though I wasn't sure about number 2, I know number 3 and number 4 would be more important than number 2 because of what I mentioned earlier about the pressure. But which one is more correct? Even if number 4, let's say it is correct, which one is more correct? What is a paracentesis? What is the question asking? It's asking for the patient to actually, I was asking it like someone was going to answer, sorry. Forgot I was recording. And you're not actually here with me. So, so you're basically wanting them to do the teach back. And the teach back for a paracentesis is going to be that they understand that the physician is going to be removing 2 to 3 liters of fluid. Now, if it said the CNA will be removing 2 to 3 liters of fluid, would that be correct? No. And is it because CNAs are not amazing and awesome? No, it's because that's not part of their scope of practice. So again, those little words, well, little and big words can mean, it can change the whole question. So the correct answer would be number 3. That shows that they completely understand how the procedure is going to, what's basically going to happen, and is the, almost did Kaplan language, which wouldn't make any sense. So it's called credited answer is number 3. So again, if there's any questions, you guys on Friday, of course, let me know. Okay, so let's move on. All right, so we're gonna go over depression first. And I wanna say a couple things before we do this, which is, excuse me, my dogs are shedding so much, it's getting into my lungs. Okay. So medication is a big part of, or usually and can be a big part of treating depression as well as anxiety. It doesn't always have to be in some cases, and I'll talk about that as we go. But I do want to mention at the very beginning that next week is, well, not next week, Friday is pharmacology. That's when I'm going to review the medications for depression and anxiety, because those have a big correlation. And I'm going to teach you my medication madness method. And from there on out, that's going to be a part of our weekly discussion. This will make more sense when we actually do it. But I use Quizlet, and I basically type it in. I teach you my method, and we go over specific medications, like the categories, for example, like Prozac. And if you don't have to take notes on this, trust me, or if you want, you can. But this part, we're going to go over on Friday. I just don't want you to think you're missing it, because of course, that's something that's going to be very, very helpful in your career in general, because again, you're going to see depression and anxiety and other disorders that we'll talk about the medications, kind of like we did with, for example, when we talked about schizophrenia, what's actually happening in the brain, too much dopamine. Why do we give antipsychotics? Because it reduces dopamine. What if the dopamine, all of that, but I have a special method that I've talked about. So we'll do that Friday. So kind of put that aside if we can for now. But please do note that there are different ways to treat different types of depressive disorders, as well as different anxiety disorders, which I'm hoping either read about from the different chapters, the chapter 23 and 25, or from this PowerPoint, or from the NIH link for anxiety. Okay, with that said, let's go ahead and move forward. So expecting that you did the reading, again, I'm not gonna, regurgitate what you read, because why, that doesn't make any sense in my opinion. So I give you the other stuff. So, and I'm gonna say it one more time. So every week, as of starting basically Friday, we will always have usually 1 to 2 NCLEX questions in relation to psych, and we will continue adding to our Quizlet medications. And the method is beautiful, and it becomes this wonderful way of being able to hopefully make connections. And I've, at least from the students from the last 5 years that I've done this with, not just in psych, but specifically psych, I don't know why it tends to, it's just, you'll see. It's pretty wonderful once it all comes together. Alrighty. So I'm not gonna go through this PowerPoint and read it to you because that would, you can read. So I'm gonna give you the stuff that isn't in the PowerPoint or explain maybe in a little more detail. So depression is something that I would say is probably one of the most commonly understood, or maybe not understood necessarily, but known thing that the layperson would know. So if you mention the word depression, most people have heard of depression and have an idea of what it means. However, what I want you to get from it is really the difference between all of us here and anyone listening to this. I'm sure, I mean, nobody has anyone that I've ever met, even myself, which I would consider a pretty jolly person, if you will. And I mean, I still have days where I don't feel 100%, or maybe I'm a little bit down, and there may actually be no reason. Nothing happened. I just may feel a little bit down. My energy might be a little bit low, and there's no reason. There's no menstrual cycle coming. There's no nothing going on in my life that has caused it. It just happens. So, or there could be the, I didn't sleep well the night. I'm just using myself as the example. Maybe I didn't sleep well the night before, and I have a lot going on. So that could also cause a little bit of, just having the feeling doesn't mean you have the diagnosis. That is the key takeaway there. And that's where we come into what I want you to really, really understand. And this is going to help in all areas of nursing, is having a differential diagnosis. So not just with depression, but just having a differential diagnosis. For example, so we go into, let's say, your wife, husband, whomever, you're starting to notice some mood dysregulation, and you may bring up and say, I've noticed you're not acting as your normal self. And again, we all have a different baseline, so that's important to note too. So my baseline is going to be different from someone else. So just because somebody else isn't acting maybe the way that I am doesn't mean that I can look at them and say, well, they must be depressed. No, my baseline is different. So we need to take that into account, of course, as well. So let's say I notice, I'm not married, but let's say I noticed, I said, oh, honey, I noticed that you have been sleeping longer, and they're having the symptoms from the DSM-5. I am not going to tell you what they are. I don't expect you to memorize what they are. What I think is important, to tell you the truth, I don't even have it memorized, and I've been doing this 12 years. That's why we have the book. and I'm laughing because, I mean, most people that work in our field don't have it memorized unless they're writing prescriptions. Other than that, we know we look in the book, and if you fit the criteria for, MDD, which is short for major depressive disorder, or if you fit, the it's on your PowerPoint, the premenstrual dysphoric syndrome, I believe, is it, or disorder. If you fit those categories, then you're diagnosed with it based off of the DSM-5. But normally what happens is we kind of maybe notice, wow, I'm not feeling my baseline, or maybe somebody else kind of maybe notices it as well. And then I call it the cycle. And this is kind of hard to lecture about, especially with you not, well, even if you were on here, because there's so much variation with mental health. It's not, oh, I see you have a boil on your foot, right? Or, oh, I see that you have a pimple on your arm, or something like that. It's a very distinctive, like, okay, this is what it is, and we treat it, and the treatment may not work, so we use a different treatment, but it's a little bit more, well, actually, in my opinion, most things in those type of situations are much more black and white than where mental health is. And this is where I'm going with this, the example of being able to have that differential diagnosis. And what does that mean? Being able to, if you walk into a psychiatrist's office, or again, remember, nurse practitioners are able to prescribe medications. Primary care providers can also prescribe medications or see psychiatric patients, everyone that I just mentioned. from psychiatrists who are physicians, primary care providers, even gynecologists, all of them can prescribe. Everyone has their own. You're going to notice I pause a lot because I don't want to offend or whatnot, but I'm trying to be as, how would you say? I don't want to let my own bias or my own opinion blur, what could your experience be, or of course offend anyone. But in my opinion, we have to be really careful who's prescribing these medications. And I'm not saying if you work in a place where you have a primary care provider who is prescribing, let's say Prozac, I think that's a pretty known SSRI, which again, that one definitely will go over on Friday. But that doesn't mean that physician doesn't know what they're doing or they're not good at it. But in my opinion, if there's a multitude of things going on with major depression, and multiple diagnoses happening, things going on, I like the specialists, right? You have to think about that. It's kind of like if you had liver cancer, I want to go to the GI specialist, not my PCP. Not because my PCP isn't wonderful, but I want to see the specialist. So it just depends on the severity. It depends on the experience. Family nurse practitioner doesn't necessarily mean, like, for myself, I'm going specifically for mental health. That doesn't mean I can't see somebody that doesn't have a mental health disorder. However, and the same thing flipped. So I have a friend who is a nurse practitioner, and she has her nurse practitioner in family health, because at that time they didn't do mental health, and she's phenomenal. Just spectacular. One of probably the best clinicians I've ever met. And so I just kind of want to get that out there. So, okay, so back to my example. So we go into, let's say we're going to a psychiatrist, and we made our appointment and we walk in. And now, scope of practice of a psychiatrist can do medication management, so prescribe medications. Now, what medications? They usually, they kind of make that their own. They're allowed to really prescribe anything. However, many of them, and this is, again, I'm giving you this stuff outside of the book to hopefully put the pieces together. And this is more of, I don't mean to say story time, but it helps, I think, to kind of hear it and put it together, especially if you don't have a lot of experience with it. So working with psychiatrists for years and years and years in all different realms, from addiction to major depressive disorder to panic attacks, OCD, schizophrenia, all across, a wide variety of different things. Different psychiatrists are comfortable prescribing different things. For example, I had a patient who was in a residential treatment facility. And remember, residential doesn't just mean it has to be addiction. There are residential facilities for mental health as well, or for both, together and combined. And this one particular psychiatrist, who I still talk to this day and just adore, he's a hoot, if you will. He's got to be like 87 at this point, and he's hysterical. He's actually the medical director at Good Sam, so you might know him. And he wouldn't mind if I talked about him because I just adore him. So, and I think he's brilliant. And he's in recovery, and he mainly, he can, just because he mainly sees addiction or those suffering with addiction doesn't mean that he doesn't treat other things, right? So he is comfortable prescribing. For example, I had a patient who was having horrible back pain, and he prescribed Flexeril for that because this patient normally was taking opiates. And of course, we're trying to get this patient off of opiates because they became an issue long-term. And unfortunately, she became dependent on them, and it was starting to impact her life and her daily functioning, which is also a very important word. Remember that. Your impact of your daily life and how you function. That's a big part of most diagnoses, depression included. So keeping in mind that different psychiatrists and those working in our psychiatry world, if you will, or mental health world, they kind of can put in their own perspective of what they're comfortable prescribing. And yeah, just wanted to kind of get that out there because I think that's important. And okay, so let's say I'm walking in and I'm, you know, with my significant other and we sit down, and this is my opinion completely. And this I will say, and I am happy to say in front of anybody, if you get a diagnosis on your first meeting with a healthcare provider, unless they sit with you for like, or with you for a week, I'm sorry, which they're not obviously going to be, you go in and usually psychiatrists or NPs, they do medication management. Some do therapy, they're allowed to, but some don't. Some just do medication management and then also say, I think it would be helpful for you to go to therapy. And we'll talk about that because that's not a big part of what your reading is. And so if I sit down and they prescribe, I mean, or it doesn't mean that they can prescribe immediately, but if they're giving, okay, oh, you have MDD, generalized anxiety, this, that, the other on day one, I'm going to have a problem with that. And I think you can see why. Off of one visit, can you really tell exactly what's going on? That doesn't mean you can't necessarily give some medication or treat. For example, I have cyclic vomiting disorder. So the first time I met with my physician in regards to the fact, why am I throwing up all the time? And it has to do with the fact of when I went there, it didn't matter that we didn't have a diagnosis at that point, right? There, of course, the first thing everyone thinks is pregnancy. And then, you know, that was ruled out. And what are you eating? All of that stuff. But we could at least treat the symptoms in that moment. We knew that. So I was given Zofran, which is an antiemetic. So I'm giving you my opinion as far as if you walk into a psychiatrist's office or NP or whatnot, and you're diagnosed day one, you have bipolar 2 disorder. We're going to start you on Lamictal and da 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 da. That's a red flag to me. And I think that most people in general will agree, unless somebody has a history and walks in and said, I was treated 2 years ago, these are my symptoms, this is exactly what's happening. So I'm giving you all of this information that probably seems like, why is she telling us all of this? Because I want to try to build the bigger picture and the critical thinking aspect, not just, okay, you need to know what anhedonia means, which by the way, I'm sure you read, means no pleasure. And that it means not getting pleasure from activities and just not feeling any joy. And you're going to see a lot of that documentation when you go into clinical, if that ever, never mind. We'll talk about that on Friday, I'm sure. So I wanted to kind of paint that picture for you on who can prescribe and what they can prescribe. There's some medications for addiction that they cannot prescribe, but that's not what we're talking about today. We'll talk about that during the addiction talk. So, okay, so now that we went over all of kind of the storytelling, if you will, let's get down to a couple of the terms. So this chapter for 23 really has to do, obviously you read it, has to do with depression and how do we know somebody has depression? The DSM-5, do they meet the criteria? And even if you don't meet the criteria, does that mean that you still can't be treated? No, it doesn't. It doesn't mean that you still can't be treated. You don't necessarily have to fit the criteria to be prescribed something. Now, you can't write down patient has, depressive disorder or whatnot, but you can say patient is experiencing this. And as long as you have that documentation to back it up, you don't have to necessarily have the 100% diagnosis of the DSM-5. And again, to you, that you're not going to need to worry about that unless you continue on in your education. I'm just telling you because I think it's kind of cool to understand. And, but it's pretty rare that does happen, that people don't actually fit the criteria. I've not seen it very often, but I would say one of the most common ones that I see are people that are coming off of drugs or alcohol. They may not fit all the criteria, but they're feeling a certain way because they're, circumstantially depressed, and medication still may be given as well as therapy, or one or the other. Okay, so serotonin syndrome, very important. This is important for us to understand. And why? Do you need to know every single thing about it? No, but you need to know it exists because serotonin syndrome, like tardive dyskinesia and NMS and all of those things that we've talked about with schizophrenia, serotonin syndrome there are two major things that I have seen. And again, you've done the reading, so I'm giving you the I guess we can call it the T, the extra. So serotonin syndrome and suicidal ideation, or rebound suicidal ideation. And let me explain those. So serotonin syndrome is one of the, I think, the first things in the chapter. So you probably already really, I'm sure that caught your eye. It's too much serotonin going on in the brain. And that usually happens, either you can be sensitive to it just in general as a human being and get serotonin syndrome, or there's just too much serotonin. And that usually, I've literally, I think, I don't even know if I've ever seen it. I've never even seen it in a patient. I only have had a friend who had it. So, I mean, I don't want to, I'm sure they gave all those statistics or whatnot, but it's not super, super common. However, it's very important to notice the potential of somebody may be having it because it can cause death. So knowing what the side effects are. So number one, the most common reason that this would happen is if let's say I'm your care provider and I am giving you, and again, I'm going to use Prozac. I'm giving you Prozac, and Prozac's max daily dose is pretty darn high. It's 80 milligrams. Let's say you're on 60, and then all of a sudden you're at, the health food store, and then you're like, oh, this looks good. I'm going to get this, and this, and this, and this. And that can also have effects on serotonin in the brain. You can potentially, that would be what I would see as the most common reason for somebody having serotonin syndrome. And that's why it's so important why we ask patients what they're on and explain to them, if you're gonna take anything over the counter, please let us know because it can have an interaction. It really can, especially in my experience, psychiatric medication. So serotonin syndrome, you're gonna notice, so let's say you're working and you notice your patient, all of a sudden, you know that they started taking Prozac a couple days ago, and all of a sudden you're noticing, okay, they have diarrhea, which is actually a normal side effect. That's okay. But okay, now you're vomiting. That's an adverse effect. That's not good. What else is going on? Usually you're going to see muscle rigidity, possible confusion, and the patient can actually go into a coma. Most of the time, we just can decrease the medication. We don't just stop it, but decrease it, and then, wean someone off of it, and then the physician will make the decision whether they're just not good with serotonin in general, or if, can they stay on the medication, or do we just need to lower the dose? Like, what's going on, basically. But what's the most important for the nurse? The nurse is the one that will probably be the one to notice symptoms. And so it's good for you to know if somebody's on this and they're showing symptoms of this, that something's going on. Now, let's say they have multiple diagnoses, because there are many people that have multiple diagnoses of mental health disorders. You can have somebody that has schizoaffective disorder, a major depressive disorder, and generalized anxiety. And they're on medications that all kind of look like, oh, wait, are they having tardive dyskinesia? Are they having serotonin syndrome? What's going on? And that's normally also why we try not to start multiple medications at once, because we want to be able to know if there's a problem, which medication is the problem. Sometimes we might do one or two, but that's just a side note to think about that can be potentially dangerous. Okay, so MDD, if you see that in the chart, that does stand for major depressive disorder, and that again is found in the DSM-5. You can look up what the criteria is for that. The other one that I think is pretty important is the premenstrual dysphoric disorder, and that one has to do with exactly what it says. So premenses, and everyone's different, and it can last until like maybe 2 to 3 days even after you have your period. Just use the layman's term. And for this one, I have seen patients that do one of two. It depends how bad it is. So if it's really bad, I've actually seen patients prescribed certain medications that will help them get through that. Now, how long does it take most antidepressant medication, or sorry, not antidepressant, or antidepressants to work? I mean, 3 to 6 weeks. So of course, we're not just going to have somebody take it, maybe right before their period, but we do have other medications that are not SSRIs that we can use that work quicker. And depending on the physician, they can make that choice. Or maybe they're on, this is usually what I see, is that this usually does correlate with depression. So somebody usually has depression, but then it dips way down. Again, there's a spectrum. So they may be on, I'm going to use a different one, Lexapro, which is an SSRI, also called escitalopram. That's the other name for it. And let's say they're on 20 milligrams. And then the physician, well, this is the most common thing I've seen. Then the physician will say, 3 days prior to menstrual period, increase dose to 30 milligrams or 40 milligrams or something like that. And go back to original 20 milligrams 3 days after menses monthly, or whatever it may say, whatever the order says. And I've had a lot of students ask, when they see that, they're like, why are they, what's happening? So that's usually how it's treated. And again, it depends how bad it gets. And then anhedonia, we already talked about. Differential diagnoses, again, I think is just the most important thing to remember. We have to rule things out and look at it, because it is, okay, like I said before, ADHD, anxiety, and mania look very similar. Which one is it? I need time with you. So I can write down, ruling out major depressive disorder, ruling out this or that, and that can be okay. But it's really important to get a true diagnosis so that we're able to treat properly. Because if I give somebody an SSRI who's bipolar, that can actually potentially push them into mania. We'll talk about that when we talk about bipolar disorder. So we want to be careful. All right. So now I gave you kind of all the extra stuff, and we'll just go through this quickly, just if there's anything I think I need to add. As we talked about before, affect is very important, our own affect, as well as being able to see in our patient's affect. And it did give all of the definitions in the beginning of the chapter. But I would say probably the most common ones that I see would either in somebody with depression, a flat affect, which has to do more with basically there is nothing there. There's no expression. There's a very just kind of like, I think we did this in class. I think I Duncan do it. I can't remember, but just kind of go flat. And then the other one would that I'm just giving you the ones that I tend to see the most of with depression would be flat and restricted. So it's restricted has to do more with, it's just not, I actually had a patient Monday who had a very restricted affect, and it was just reduced from what, and again, there's no normal, but from what you would expect to see. So, we're talking and basically I'm doing the interview for him to enter the program, and there's really a reduction in the range of what he'll give me facial affect wise. So that would be restricted, and that makes a lot of sense as far as the word, which makes it easy. And really those are the two. I'm not saying the other ones aren't important, but I would say those are the two that have the most to do with depression in my experience. And the other ones we'll talk about when we get to those diagnoses, especially bipolar disorder. Okay. I think I mentioned this before, but again, depression just doesn't mean I'm sad. And I think we've talked about somatic symptoms. So somatic symptoms have to do with your body and what can happen. So somatic symptoms of depression can be being very lethargic, increase in appetite or decrease in appetite, stomach upset, all sorts of things. And can actually really, again, it impacts your daily functioning of your life, and your brain can, you probably heard people say brain fog. So it's almost like it's hard to create a thought. And what's happening in the brain? Serotonin, like I've said before, all of your neurotransmitters do multiple things. It's not just serotonin that has to do with, that's not the only neurotransmitter that has to do with depression. And this will come up a lot more with medications. So I don't want to say too much about it right now. But for example, norepinephrine and dopamine also have something to do with depression. So that's why it's not just SSRIs that we give. We give SSNRIs. We give medications like Wellbutrin that work only on norepinephrine. And again, this will all be gone over on Friday, and then continue to build and explain why and how would we know, or how would we choose what we're going to prescribe. So that's a different lecture. That would make this way too long. Okay. So, and actually, even after I talk about depression, I'm going to do the anxiety one separate and post it tomorrow on Wednesday. So, okay. Going down here, I'm just seeing if anything I didn't. Yeah, we've already talked about all this stuff. Talked about substance abuse can definitely, especially once we get off of the medication, but also if somebody is abusing substances, like let's say drinking, you know, a liter of vodka a day and taking an antidepressant, it cancels out the antidepressant. It makes it to where the antidepressant doesn't even work. I've never gotten an answer from a psychiatrist why, but I guess they've done brain scans that have shown that the serotonin, it like just does nothing. And how does serotonin work? So if you have a reduction of serotonin, what does that mean? What it actually means is, and this is why if we give something like an SSRI, what is it actually doing? It's not producing more serotonin, right? It's just keeping it longer in that synaptic gap, that cleft. That's all it's doing. It's just keeping it there. So the longer that it's there, the more we're going to feel it. And when, let's say somebody is depressed, and a lot of the times my patients will ask me, well, how am I going to feel? Because I've been depressed so long, I don't know what normal, and I'm doing quotes, feels like. And we have to be really careful what we say, because a lot of people will say, oh, euphoric. No, that's not good. That's not how you're supposed to, I know it sounds good, but that's not how you're supposed to feel. And then you're giving not expected expectations, right? So I love the word, and I don't know if I mentioned this to you guys before, but well-being. So I like that word. You're going to hear it on Friday when we talk about medications, because it's part of learning how serotonin works in the body and in the brain. But explaining to a patient, usually what I say is, your body usually will feel a little bit lighter. Waking up in the morning might not be as difficult. It depends on the type of depression that they're suffering from, and what, because it's going to affect everybody differently, right? There's not just one way, and everybody sleeps too much or is in bed under the covers, you know, how all those commercials are. It doesn't look the same. And then all of a sudden there's a butterfly at the end because life is perfect. That's not real life. So depending on that person, I usually will say, I'll fit it to them specifically and say, oh, well, you know, I noticed during our talk that you had mentioned how you are not sleeping enough, because it can be the other way too. That you're not sleeping enough and you're having a lot of rumination, and you feel that it's hard for you to be a mother because it's hard for you to be able to find pleasure in doing things like that. So if do you see how my tone is changing? It's so weird. God, it becomes a part of you. And you may start to notice the world's not just going to change and you're going to want to get up and run 12 miles every day and life is perfect. That's not what's going to happen. And we also need to let them know when the medication is going to start working. So an SSRI takes about 3 to 6 weeks. So keep that in mind, that one specifically, because those are usually the ones that are prescribed, are SSRIs and SSNRIs, which we'll talk about on Friday. Some people will start to feel maybe something after a week or two, but the norm is 3 to 6 weeks. And then usually at that point then, and we'll talk about that also in pharmacology, we might make an adjustment of dosage and whatnot. And keeping in mind that every medication has a target dose. If I gave 1 milligram of Prozac, that does nothing. The starting dose of Prozac is 5 milligrams, and that's with teens or children. And then the max daily dose is 80. The average dose is 20 to 40. So, now do you need to know that? No, but it's good to have an idea of we could potentially do other things if this isn't working, as well as it's not just about the medication. We don't just throw pills at people and say, good luck. They may need treatment. They may need to go to an outpatient treatment where they're doing group therapy, or individual therapy, or whatever's going to work for that person. We have to meet them where they are and what they're comfortable with. And therapy can be very, very talk therapy. In my opinion, just again, this is my opinion. I think everyone should be in talk therapy, especially those of us working in healthcare. I openly say that I see a therapist once a month, and it's once a month, not once a week, because I'm not depressed, but it's good to have someone to just objectively hear me rather than going to my friends where it's very, very different, and just being able to kind of unload that feelings of, this happened and this is how I'm feeling about it, and be able to, I can process things pretty good because I've been in psych so long, but you don't want to burn out. So that's just a side note. Okay. So we don't want to give them unexpected expectations of how things are going to be. So for that mother, I might say, well, you might notice in a couple weeks that things might just seem to be a little bit easier. And then as time goes on and the brain continues to, take in that serotonin where it's supposed to be, and I see that you're now going to be in therapy once a week and you're doing treatment with us to get you out of that crisis mode, because somebody might be in crisis mode and get hospitalized because they were suicidal, right? And what's the first thing that we ask if someone's suicidal? Do you have a plan, right? Because they might need to be 5150, which we all know it. We all know what that is. Okay, so here's the diagnostic criteria. You can read this, of course, on your own, so I'm not going to go over it, but just knowing that there is criteria, that's what's important. There's, of course, different potential things that can happen as far as, for example, and this isn't exactly what the slide is saying, but there's a genetic component, there's a life component, there's all sorts of things to really, that's why it's good to get a good history. And that's why I don't like when I see diagnoses after a first visit. I want to, unless they have a really dated history of this, and now they're coming to me, that might be different. But a lot about life and what's going on and what has happened and genetics. And for example, if you're going to prescribe a medication for depression, I want to know anybody in your family with your bloodline, if you will. That's like a dog, but you know what I mean. Then I'm going to go with that medication because you have a higher chance of it working and not having as many side effects, again, which we will talk about on Friday. Something I want you to keep a lookout for is this, and this is very important. That's all I'm going to say. It's very important because some people don't realize this, and suicide does peak. So suicidal ideation has a peak at age 75. Middle age tends to be another one, and I think that many people can understand for both of those reasons. I mean, I can say college too. I mean, college is very stressful, this, that, the other, but statistics show middle age, and usually it's that, oh my God, like, what do they say? Midlife crisis kind of a thing can happen, and or increased stress with work. I mean, like right now with COVID, we're seeing so much depression and anxiety because people are stuck in their house, and that's not, I mean, as human beings, we're supposed to, or not supposed to, like saying that, we're meant to socialize, right? So keep in mind, this is important to watch too. The second peak can be at age 75, and the statistics are in your book as well, because where I got this PowerPoint. And this is really scary. We actually have a program where I work where it's called the OATS program. And a lot more people of this age range are committing suicide because maybe their partner died and they're like, well, life isn't worth living anymore, or all my friends are dying, or sick, or, have all these comorbidities, and just say it's not worth it anymore. I don't want to do this. Or they themselves don't feel well because maybe they have ailments that are causing them to feel depressed, and they're just like, forget it, I'm done. I'm 75, it's over. So that's very important. Risk factors, you guys can read all about that. And the ones that I wanted to really point out has to do with here. So lack of coping abilities. And that's where therapy comes in, right? That's why I say we don't just throw pills at people and say, okay, good luck. Well, okay, maybe this person doesn't know how to like decompress, or like myself, and I'll use myself as an example. I used to be an awful ruminator. And oh my God, I can't believe this, or oh shoot, did I do this wrong or right? And I thought about that actually while I was preparing for this lecture. I was thinking, wow, if I was still having that issue now as an instructor, because I know for sure there's 59 of you, not all of you. I'm not everyone's cup of tea. I have, I think, almost 300 students now at this point. And I'm not saying everyone hates me or there's people that hate me, but I'm not everyone's cup of tea. And that's okay. I don't have to be. I mean, I hope that you're getting what you deserve from what I'm, giving you from lecture and the right support. But that doesn't mean that maybe I'm your favorite thing in the whole world. That would have eaten me alive 10 years ago. So, but now I can cope with things much better because of certain abilities of being able to. I went to therapy and I'm not trying to self-disclose too much, but I think I mentioned my parents died very, very close together at the same time that I was going through a divorce. And it was a very difficult time in my life. And I was opening my first business. So everything together just kind of woo. And I will self-disclose this because I think it's important. And you all have seen me enough to know. By the way, this is about to wrap up. I know it seems like it's going on. I'm not going to go over our time limit. And the anxiety one is shorter because that one has a lot to do with medication. The depression one, and depression and anxiety, I've said this before, they often go together as far as diagnoses. Not always, but they can. And that's why a lot of antidepressants also work as anti-anxiety. And we'll talk about that on Friday. Okay, so you've all seen my affect is, very active, if you will. I'm in general a very, very happy person. I feel very lucky for that. And however, during that time, things happen in your life. All of a sudden, boom, you can lose your job. This can happen. And you're just so overwhelmed. You cannot cope and you need that help. You just hit a wall. I've seen people come in with suicidal ideation, get hospitalized for the first time at age 35. Up until then, everything was fine. They work at Google. They made $350,000 a year, and all of a sudden hit a wall and end up in the hospital because they are just so depressed and so stressed and just can't cope. So I wanted, again, that's why we're doing this, to give real life situations rather than just what's on here. We always want to rule medical things out. It is so important. You can have a thyroid disorder, right? And instead of depression, your thyroid disorder could be causing your depression. So we always want to actually look at other factors, not just jump to conclusions. That is my opinion. Some don't do this, but I would want to know and check for vitamin D. Vitamin D is actually a big, most everyone of every skin color actually has a vitamin D deficiency and doesn't even know it. And that can contribute to a little or a lot of depression. They've been linked, let me put it that way. So we know about the neurobiological stuff as far as serotonin, and we talked about family factors, social factors, like what I said, things going on. And again, is it a crisis that's happening? And not everybody needs a medication. Now some do. If this is chemical, major depressive disorder and things are not getting better with therapy and somebody really doesn't want to use medication, sometimes, you really have to, it takes some time, but sometimes we can go the natural route, acupuncture. There are many other things that we can suggest. I do want to put that out there. And I deal with a lot of patients that are medication resistant, and I never want to, and it's probably not the best way to say it, but I always say I'm not gonna, no, I don't say that. I'm not going to, we really try hard here not to pressure people to take medication. However, the benefits could potentially be this, that, or whatnot. So again, we want to meet the patient where they are and not pressure. We want them to buy into their own treatment, right? They have a treatment plan and we want them to buy into that. Now, that sounds like we're trying to solve something, but I think you understand what I mean. So again, physical examination, look at things, look at are they abusing alcohol or drugs? Like, what else could be going on? Or is it depression? And you as a nurse, you're going to be doing a lot of assessment. So this is something that you could catch something and actually help the patient. Sometimes it takes years for people to feel better because they don't get a proper diagnosis. That happens all the time. Do you know how frustrating that is for the patient? They feel like a lab rat, and it's awful. And too, on the flip side, sometimes it's hard because it's the brain and I can't see and say, oh, yeah, you need this, exactly. So, but I think knowing that actually helps validate how the patient is feeling in my experience, and they really appreciate that I'm able to understand and not just be like, just take this medicine, I don't care about you, and understand the fact that I know that this is frustrating, or it sounds like you're frustrated, and I can, the therapeutic communication stuff. These are some different things that can happen as far as having depression. We talked a little bit about it earlier, but these are the nursing diagnoses specific. We will talk about all of that on Friday, so we don't have to do that now. The only thing that I really want to bring up is ECT. I mean, you guys have probably heard they call it shock therapy. That's not what it is. This is usually more of a last resort, and I'm gonna, instead of explaining it, honestly, pull up a video on it. We do it at El Camino. It's easier to, I think, see it. You're basically, it's a quick procedure. It's done over, it's a prescription, really. So it depends on how long they want you to do it. But this is not a first line thing that we just automatically do. This is if somebody's medication resistant, meaning the medication or whatever therapies we're doing are not working. Another thing I love that they mentioned this TMS. It's amazing. I actually used to do this. It's called transcranial magnetic stimulation. And that's kind of what I would at least say. So would be before ECT as well. So it's basically where they put this. It's kind of, you can again look it up, but kind of like a little thing. There's 3 different ones, I think, at this point. And when I said I used to do it, I mean I used to perform it and supervise the technician who did it. And it's like a magnet that basically goes on a certain part of your brain that helps naturally stimulate that. It basically works like an SSRI, but it's not systemic. It's very direct to that one place in the brain. That way you don't have side effects, such as like you would get from potential SSRIs, because you're only going to specifically the brain, because remember, 90% of your serotonin is in your gut. So this would not stimulate the serotonin in the gut. And we can talk more about it. Honestly, a lot of people don't even know what, even psychiatrists, a lot of people don't really understand it. So I'm not going to go too far into it, but I want you to know that other things do exist. I've never heard of this before, other than the blue lights and things like that. But I don't want to focus too much on this, but we can, if you have questions about it, we can definitely talk about it on Friday. All of this we have talked about. Definitely cognition and memory can be affected with depression. I think sometimes people don't give depression the credit that it deserves. I don't know if that is the right way to say it, but it can really be life altering. And so, I mean, and if you've even felt it for a day, or like if you've had someone pass away, that feeling, imagine feeling that way, but all the time for until you maybe seek treatment. And then treatment may take, who knows, the first treatment round doesn't work, they have to do another medication. Now it's ended up 6 months and it's just awful. And then you're supposed to try to function and go to work and support the family and do all of this stuff. So all of this. Milieu, if you guys don't know what that means, milieu therapy means like going to an IOP, you're in a milieu, so you're in a group of people. That can be really, really helpful. When somebody is feeling depressed, we definitely want to make sure that we watch out for one thing that I really want to mention, having to do with suicidal ideation. So if all of a sudden we see somebody feel so good, they're almost euphoric, and yes, that could be good. You're like, oh yeah, the medication's working, you're feeling better. That can actually mean that they're suicidal. So we have to, I know that sounds, and I'm sure you've heard of it in your, I was just gonna say your psych theory, that's what we are. Sorry, I teach a lot of clinical, but that can be something to watch out for as a practitioner, or if you're working in your clinical, is if somebody all of a sudden who was depressed is so not depressed, or they're starting to give their stuff away, or there's all different sorts of things that could be an increased risk of them hurting themselves, or potentially trying to take their own life, or just not just, but self-harm, like cutting or pulling out hair or things like that. And why do people self-harm? Usually it has to do with, I'm going to get this pain so that I don't have to feel the pain that I'm feeling inside. Okay, so of course the goal is, there can be, when we say that there's relapse, there can be a relapse in depression. Relapse doesn't just go for substances, but we hope if that happens that we get our patients stable again. Do they have to be on medication forever if they do start medication? No. May they need it forever? Maybe. We don't know. We don't know. And we can always, like myself, back to my example, I was on Lexapro for about 1.5 years because my anxiety was so bad and I couldn't sleep, and I, because all this stuff was going on. I mean, that was a lot at once. I mean, literally within 2 years, and then running a business and working 17 hours a day, it was a lot. And it can really get to you, and you can become overwhelmed. And I was having trouble functioning. And at that point I said, nope, can't do it. And ask for help. And that's one of the hardest things to do, is to ask for help. For a lot of people, is to be able to say out loud, I think I'm depressed. I don't know what to do. And where do I start? And when you're depressed, usually you don't have motivation. So then it's hard to even get that going. So these are all things to think about. We already talked about this. Okay, so for this one, I'm gonna stop here. I think I gave you enough extra and kind of information, hopefully. Again, I don't like doing it this way. I would much rather do it in person. And but I think that these two concepts are much easier to understand via reading than something like schizophrenia. Like schizophrenia, I would say, nope, we're doing it in person and we'll move things around. So that's why I think that we're okay doing depression and anxiety via the way that we're doing it this way. So this video I'm going to download, and anxiety is going to be much shorter, not because it's not important, but because it's going to weave into each other so similarly. And we're going to talk about anxiety as well on Friday, because you'll see why. It goes a lot with what we're going to talk about with pharmacology. So I'm going to stop this part here. I hope that you got some good visualizations of this. And we're going to have plenty of time on Friday, guys. Please write down questions, or if you need any clarification, or if you have anything that you want to add, or stories. It's kind of a rude word. Or examples that you want to share, please feel free. I do think that helps tie into the memory a little bit better as well, and helps us be sensitive to the fact of trying to kind of almost put yourself in your patient's shoes a little bit, if you will. Okay, well, I'm going to stop this here since no one can cut me off because you're not here. Otherwise, I'll just keep going and start telling you what I'm doing for the rest of the day. So this should publish Wednesday, probably by like 10:30 or so. All right, thanks, guys. Anxiety will be posted by Wednesday night.